Welcome, everyone. We are ready to get started. I am so excited to have you all join us for the informational webinar regarding the Pediatric Readiness Quality Improvement Collaborative. Next slide, please. We are grateful for our HRSA colleagues and the EMS for Children Innovation and Improvement Center. This collaborative is supported by HRSA. The contents are those of the authors and do not necessarily represent the official views and of nor endorsement by HRSA, HHS, or the U.S. government. Thank you for joining today's event. Attendees will remain on mute for the entire presentation. The webinar is being recorded, and the recording and the slides will be posted online. Please feel free to add your questions into the Q&A feature, and they will be answered throughout the presentation. These are the topics that we will be covering today. Next slide, please. I will now turn it over to Laura Garcia, who is going to proceed on to the next section.
Good afternoon, everyone. Can you hear me okay? So we're going to go ahead and get started this afternoon. Again, go ahead, next slide, please. So most of our hospitals and EMS agencies have similar mission statements with words like high quality care, without discrimination, ethical and safe. So we're all kind of starting from a similar place. We have an obligation as these agencies to provide the right care in the right place at the right time to anyone who crosses our threshold, or even a few that get dropped off in the parking lot. As an ER nurse or physician or EMT, we want to fulfill that obligation. We want to be prepared to take care of children in our community, but are we? Next slide, please. So where do parents take their children when they have an emergency? Well, come to find out, about 80% seek care in their local emergency departments. That's about 28 million children. Of the local EDs, over 90% of them are general EDs, and less than 10% are pediatric specific or designated pediatric areas. And of those general EDs, over 70% see less than 15 children a day. So why is that important? Two reasons. It shows us that all EDs, all pre-hospital care places need to be prepared to take care of pediatric emergencies, and only a small percentage come by ambulance to the ED and thus may be diverted to a pediatric capable facility. These low volume EDs, they cannot measure or benchmark the effectiveness of their system to meet the needs of children, nor can they assess the impact of their system design on childhood morbidity or mortality. Their numbers are just too small. So aggregate uniform data collection can help us determine the impact of systems of care on patient populations like children. It can show us the inequities or problem areas and drive opportunities for improvement. Registries are also often used for rare or uncommon conditions. And for the purposes of low pediatric volume EDs, critically ill children may be considered rare. So QI efforts are needed to understand the impact of pediatric readiness on delivery of care. Next slide, please. So enter the National Readiness Project. It's a comprehensive web-based assessment of over 4,000 U.S. emergency departments. It was based on the Guidelines for Care of Children in the Emergency Department, which was endorsed by ENA, ASAP, AAP, and EMSC. And it provides a national snapshot of pediatric readiness in the EDs in the United States and its territories. The first assessment was in 2013, and then it was followed by QI efforts, and then another self-assessment, reassessment in 2021. And there was a marked improvement in the overall score. Next slide, please. However, about 81% of the EDs reported barriers to guidelines and implementation, and these included cost of training personnel, lack of educational resources, lack of a QI plan for children. As you can see, those hospitals that had any QI plan scored a median adjusted score of 88, compared to those that didn't have a QI plan, and they scored about a 62. Of note, only about 45% of those EDs had children included in their ED plan. It's very cool right now because several studies have recently highlighted higher readiness scores can lead to lower pediatric mortality and morbidity as well. Next slide, please. So intuitively, we would think having recommended pediatric equipment, pediatric educated personnel, and pediatric specific policies would be enough to increase the ED's readiness. However, it was noted that unless a PEC or pediatric emergency care coordinator was present, many hospitals never implemented or sustained readiness to care for children. So as you can see the scores on the slide right there, very few had both physician and nurse PECs as well. And then you can see the scores accordingly. This led to the Institute of Medicine's call for action, which recommended that EDs and EMS agencies should appoint a pediatric emergency care coordinator. And I'm sure that's why many of you guys are participating in this right now. So why is a PEC needed? They validate pediatric specific skills and knowledge. They oversee pediatric QI initiatives. They ensure the availability of pediatric medications and equipment. So if it's been used, someone is in charge of making sure that it gets reordered or resupplied, and that people know how to use the medication and the equipment. They implement pediatric policies and procedures and disaster planning prep. They ensure that a pediatric patient is part of all of those disaster plannings, that they're included in the what am I thinking here? The drills that we do. And then also that all of our protocols, all of our policies have some kind of pediatric focus on them as well. And then they also promote pediatric injury prevention and research. So more training and guidelines are not sufficient. There needs to be someone advocating for pediatric considerations routinely, whether that's in a hospital or whether that's in an EMS agency or pre-hospital care. It's not limited to a nurse or a physician, but it could be an NP, a PA, an EMT, a paramedic. In the hospitals, it should be someone who's in the ED, who has interest, knowledge, and skills in the emergency department and emergency care. And they know where to find quality pediatric resources. It's really an exciting time right now in the field of pediatric emergency care, as these formal findings and recommendations are slowly changing the landscape to give voice to pediatric emergency preparedness. And this is ultimately going to improve the care of children from pre-hospital to ED, from hospitalization to discharge and injury prevention. Next slide, please. So I'd like to share a couple examples of how QI has helped my hospital improve over the years. I've been in this role for about 25 years and have seen many changes in the pediatric emergency care arena. Definitely have seen little changes that have a big impact over time. I work in a community hospital that sees around 75,000 patients a year and approximately about 11,000 peds a year. We're a comprehensive stroke, STEMI receiving, and we're certified as an EDAP, an emergency department approved for pediatrics, which is part of our LA County's EMS system. Our hospital has a level 2 NICU and used to have a pediatric unit that closed 10 years ago. That just gives you a little background. So how many of you heard the ED always or the ED never? And this is kind of an example of one of those. So the complaint was that the ED always called the NICU and peds nurses for our IV starts. And I regularly audit these charts. So I didn't think that was the case, but I needed data to support my suspicion. After auditing 2 months of charts, the data showed that the ED nurse got the peds IV stick about 70% of the time in one stick. The other starts were multiple sticks, often from the ED nurse as well, and the remaining 10% were from NICU or peds. And it sounded pretty good for the ED, but I wanted to do a lit search and find something that I could compare. This wasn't an easy stat to find, but I found a couple articles and documented our high success rate. And we shared those findings with the ED, the peds, and the NICU staff meetings. And uniquely, ironically after that, we didn't get very many complaints about our IV sticks anymore. We weren't doing badly, but we could be better. So the attention that we had focused on the IV starts, we began stocking shorter IV catheters that the peds and NICU used, as well as purchasing the same NICU vein illuminator that was a little bit stronger than ours. The other findings were that we weren't using numbing agents when we started the IVs. So we invested in educating in EMLA and Buzzy. And after the education, we re-audited the charts for the use of the numbing agents and appropriate size catheters. This also improved. This change has affected children in our ED for the last 15 years. Next slide, please. Another example of the QI process and how it's improved our care is specifically to pediatric sepsis and how we approach it. For many years, I've hosted a pediatric emergency conference that would educate our nurses in regards to pediatric sepsis and a bunch of topics over 14 hours every 4 years. These nurses routinely understood about pediatric sepsis. However, we did not have any pediatric sepsis screen embedded into their assessment, nor did we have order sets for our physicians that they could easily access. We had a case where a child was seen in our ED and sepsis was not recognized at the beginning of their visit. And by the grace of God, we caught it before he was released home. The child was transferred to the appropriate facility, but his care was delayed in treating sepsis, and his outcome could have been better. Our local children's hospital reviews all our transfer cases with them bi-monthly, and this information came up at that time. So I did a sample audit of the charts to see if this was just a one-off or if it was actually a problem that we had. And we found that we were not recognizing sepsis early in the pediatric visit. So we did some lit search, we did best practice review. My physician and I, we have an EDAP medical director, which is the physician component to my role. And we reviewed those best practice acts, and then we brought it all together and we submitted some changes. And so what we looked at were universal pediatric sepsis screening at triage, a nurse and a provider badge buddies that had excessive tachycardia as well as normal vital signs for children, and then physician order sets for pediatric sepsis. And our compliance went from a low of 30% to routine practice now at over 95% of the time. We've had many good catches on subtle findings, and the collaboration of assessments with docs and nurses for pediatric sepsis has improved the care of children in our community. And I want to make it clear, these changes didn't happen or sustain overnight. It took years to accomplish, and one step at a time with many failures along the way. So next slide, please. Finally, I showed this picture of the Colorado River at Parker, Arizona. I've been coming here since I was 16, and I love coming back every year. Even though the river is still flowing along the same banks, the first time we take our boat out for the season, we have to navigate the entire river from dam to dam to recognize the changes the erosion and rocks have made to the river course, or we risk damaging our boat. I think taking on this project is similar to that. Each little change that we can implement is like a rock or stone in the river that changes the flow just a little bit, and ultimately it can change the course completely. Still the same river, but affected nonetheless. Still treating the same patients in the ED, but the care has changed just a little bit, and then a little bit more, until one day you look back and realize the impact those little changes made. I want to thank you for your interest in pediatric QI. You may feel like it's overwhelming and want to either do it all at once or be frozen by the indecision because you have no idea where to begin. One little rock at a time, you'll get there. You can do this. Whether you're representing a large pediatric regional hospital that sees hundreds of children every day, or a rural community hospital that sees less than 15. Using quality improvement strategies, you can improve pediatric emergency care based on your available resources and some of the tools we'll discuss today. We hope you find something in the following presentations to inspire you to take those first steps into improving the emergency care of children in your community. Thank you very much. And I'm going to hand it over to Robin Goodman.
Thanks, Laura. So I have had the absolute luck to work with Laura almost my entire career. We've both been pediatric emergency care coordinators, or PDLNs, for many, many years. And so thank you so much. I'm so excited you're here today. So thank you again for joining this webinar today. As I said, as a former pediatric emergency care coordinator, I am really excited to give an overview of the upcoming Pediatric Readiness Quality Improvement Collaborative, also known as PRQC, and discuss why you should join the 2023 cohort and how PRQC addresses the barriers to pediatric readiness that Laura just shared. Next slide. So I wanted to start off today with a little bit of background on the Emergency Medical Services for Children Innovation and Improvement Center, what we like to call EISC. EISC was formed in 2016 and aims to accelerate the transformation of emergency care systems to better meet the needs of children using quality improvement methodology. EIC leverages the experiential knowledge of its co-lead organizations, the University of Texas at Austin Dell Medical School and the University Hospitals Rainbow Babies and Children's, as well as partners at Yale University, Baylor College of Medicine, and the Lundquist Institute. And we also use the expertise of multiple professional societies and federal organizations to improve healthcare outcomes for children in emergency settings. EIC is part of the Emergency Medical Services for Children program, which also includes the Pediatric Emergency Care Applied Research Network, known as PCARD, state partnership grants, the MSC Data Center, and targeted issue grants. The American Academy of Pediatrics, the American College of Emergency Physicians, the American College of Surgeons Committee on Trauma, the Emergency Nurses Association, and the National Association of EMS Officials also partner with us in this work as well. Next slide. So I know I may have lost some of you when mentioning QI methodology on the last slide. And I remember when I first met Laura and she was trying to teach me how to do QI, because it's not something that I was really taught in nursing school. it gave me a lot of anxiety in trying to take on a program as a new PEC and understand how to implement quality and get people on board was really overwhelming and definitely gave me pause when I first started. But QI collaboratives are a different way to engage in quality improvement work and accelerate knowledge translation at the same time. And so it's a way of doing something with making it more fun, but also teaching us along the way. So a QI collaborative, collaboratives are defined by the Institute for Healthcare Improvement as short-term learning systems that bring together a large number of teams from various settings to seek improvement in focused topic areas, in this case, pediatric emergency care. Collaboratives differ from most educational programs in that they emphasize empowerment and engagement versus passive learning. This is, you're going to learn and you're going to do. And I think that's, especially for healthcare, I think that's where the magic happens in these collaboratives. Ultimately, participation in a QI collaborative is about improving outcomes tangibly and rapidly. We move quickly through these processes. Pediatric quality improvement collaboratives like PRQC include data sharing and communication, trust among institutions, financial support, support from national organizations, use of theoretical framework to guide collaboration, patient and family involvement, and incentives for participation at both the individual and institutional levels. We also encounter barriers during these collaboratives as well. And so things that we want to make sure we are addressing are insufficient funding for resources, legal concerns, difficulty coming to consensus on best practices, and outcome measures. And our teams will work with you to support both addressing improvements and barriers as we move through the process. Next slide. So the QI collaboratives are based on the Institution for Healthcare Improvement's Breakthrough Series model. You can see this shown here on the slide. Research has found that QI science can reduce the uptake of time of evidence-based practice into clinical practice down to 3 to 5 years instead of 10 to 20. And I know we all have seen, experienced, we know what best practice is, but we're still doing things the same exact way. Our goal really is to kind of knock that down and get the evidence into people's hands so they can improve care for pediatric patients. QI collaboratives typically focus on supporting participants in developing a project to apply and test the lessons learned with guidance and support from a team of experts. QI collaboratives follow a cyclical series of learning sessions, action periods, measurement, and then evaluation. And then once completed, EIC's QI collaboratives typically transition into a community of practice where these forums aim to sustain and build on the resources and best practices from the collaborative. Next slide. So let's talk about PRQC. So PRQC focuses on the work of the National Pediatric Readiness Project, or NPRP, and helps participating teams, hospital-based teams, take the next step in addressing gaps identified by the NPRP assessment. PRQC aims to support pediatric champions to implement local pediatric quality improvement efforts. And I stress the word local. This is what's happening in your area or your facility. You'll be supported by coaches and with networking opportunities. Hospital-based ED teams will be able to see, measure, and analyze improvement efforts in real time at the patient level through access to the National Pediatric Readiness Quality Initiative, an innovative new online dashboard created to help drive best evidence into practice. Additionally, best practice resources and tools will be shared with participants through learning sessions, fireside chats, and more. In these sessions, teams will learn how to complete an environmental scan, to prioritize areas of focus within your facility, and learn about their selected topic in deep dive sessions led by subject matter experts. Next slide. So PRQC aims to have 80% of participants establish a QI plan and implement at least one process change by December of 2024. Hospital-based teams will be empowered to address their ED's gaps by learning about 4 high priority focus areas in pediatric readiness. Patient safety, where we will focus on recording pediatric patients' weight in kilograms. Patient assessment and reassessment, where we'll work on developing a notification process for abnormal vital signs. Pain management, where we ensure that pediatric patients' pain is assessed and managed. And then suicide, optimizing screening and treatment of pediatric suicide patients in your ED. Next slide. So PRQC teams will have the ability to assess all phases of clinical emergency care processes to identify and prioritize their focus areas and implement a basic QI project focused on one or more of the identified focus area topics. Next slide. So as I said before, PRQC teams will be able to see, measure, and analyze improvement efforts in real time and at the patient level through access to the National Pediatric Readiness Quality Initiative, an innovative new online dashboard. NPRQI provides a free, secure, easy-to-use web-based platform that allows EDs to track quality metrics and performance. The platform supports local quality improvement and standardization of care. Nationally, it will support gaps or inequities in care by creating a national repository of pediatric emergency care data. To me, and I will say when Kate first showed this, Dr. Remick first showed this to me, the dashboard, as someone who had spent so much time working on quality improvement plans within my facility, NPQI is really the bridge we have needed for so long to help address gaps in care for pediatric emergency patients. And I was, I think, so excited to see it and just know the benefit that it's going to give to our work within quality improvement in pediatric emergency care. Next slide. The NPRQI reporting dashboard provides a snapshot of participation at the national level. The platform aggregates data from all participating sites, and as Laura shared, most EDs have a low volume of pediatric patients on an annual basis, which makes it very difficult to assess the delivery of care in facilities. So using NPRQI, EDs can compare themselves with other like facilities based on geography, patient volume, and resources. Nationally, NPRQI will have sufficient pediatric patient visit experiences to better understand the variation of quality across patient demographics. Next slide. And so this is an example of NPRQI's table view. Here you can see just a few of the 28 standardized pediatric quality metrics that are available that can be tracked and trended on the platform. And this dashboard or these screens would be tailored to your facility's data as you develop the dashboard. Next slide. NPRQI also provides performance reports that can easily be shared with your ED and executive leadership on a routine basis to demonstrate the progress that is being made on improving pediatric care. For me, the value here is the database. The dashboards and reporting are created for you. No need to engage with your IT department, your quality, your data group, or in my case, develop a manual process to track all of our pediatric quality metrics. The heavy lifting is truly done for you, and participating teams get to focus on the work of improving pediatric care rather than tracking all the data manually through the collaborative. Next slide. So that was a very quick overview of the Pediatric Readiness Quality Improvement Collaborative. So why join PRQC? Bottom line, to improve the emergency care system for children in your community. That's why we're all here. Is if we want to take our kids to a facility, and they should receive excellent care regardless of where they are in the country. Participating in PRQC will allow you to gain QI experience in a supportive environment. You're provided access to a centralized data platform and pediatric specific quality measures where you can benchmark your efforts with like hospitals nationally and within your region. You can actually see this in real time. You can see the impact that you're making on your community. You also have the opportunity to network with local, regional, and national PRQC team members and other team members as well, who are all committed to improving pediatric emergency care. And most importantly, this work will assist your facility in addressing gaps in pediatric readiness, which could lead to meeting criteria for pediatric recognition for trauma and/or medical centers. So thank you for your time, and I look forward to seeing you all at our kickoff meeting this summer. It's now my pleasure to introduce Dr. Tim Stade, who will share his experience with the 2018 PRQC cohort.
Hi, thank you very much. Talking to you from inside the hospital, so if you hear some background noises, I apologize. I had the privilege of being the physician lead of the 2018 PRQC hub site at Cardinal Glennon Children's Hospital. In my role in my group, we also cover many of our community hospitals. And when we first heard about the PRQC, we were wondering why we would want to join such a program. Next slide, please. And in my role at Glennon and at the community hospitals, I could see the barriers that were out there. You know, how can we improve readiness of all of our hospitals across our community? And some of the barriers include the lack of educational resources, the cost, and just the ability to come up with QI plans for children. And the first PRQC offered solutions to all of those. Next slide, please. As was pointed out by Dr. Remick and her group, having a QI program improves your pediatric readiness scores dramatically. And this slide was already shown, so I don't need to go into it. Next slide, please. After we joined the PRQC, I didn't know what we were going to get out of it, but what I did find were many incredible benefits, including improving pediatric care and outcomes, not only in our emergency department, at Cardinal Glennon, but in the community hospitals who served as our spoke hospitals. It also connects you with your community partners, not only the hospitals, but the EMS agencies and your school districts. The saying, the rising tides lifts all ships. As you're trying to improve pediatric emergency care in your community, it helps everyone. It also gave me an opportunity to connect with a lot of the national leaders in emergency care and disaster preparedness, leading to all sorts of new opportunities, including with our local state EMS, C group with the Pediatric Pandemic Network, and of course, the second PRQC that we're talking about today. And it also helps close gaps to provide equitable healthcare for all the children, not only across our state, but across the nation. And it's a fundamental problem that you just see more and more that this PRQC can help solve. Next slide, please. Just a little bit about how the first collaborative went. We are based at Cardinal Glennon Children's Hospital in St. Louis. We're affiliated with St. Louis University. Myself and Terry Kuehler, who I believe is on the call, and Mary Bixby were the medical leads. And the model was the teach the teachers. So we recruited 10 hub or spoke hospitals, next slide please, in the St. Louis metropolitan area. And they were led by physicians and nurses, people who essentially would qualify as pediatric emergency care coordinators, whether they had that title or not. Next slide, please. And within those hospitals, they participated in 1, 2, or 3 of the quality improvement projects. And you can see the hospitals listed on the left and their pediatric volumes. Some of them were as few as 800 a year. Some of them were as high as, I think we were at 60,000 at Cardinal Glennon. But anyway, we ended up a total aggregate of about 120,000 pediatric ED visits per year that we were able to do the QI measurements on. Next slide, please. And besides the importance of improving pediatric care, it made each hospital think about their pediatric care, especially the ones who don't do it very often, and celebrate a lot of wins. And this really propelled hospitals to continue to include good quality pediatric readiness strategies in their emergency departments long after the quality collaborative ended. And getting people not only to understand how this works, but the changes they can make, and sort of like talking about the little changes in the river, little changes in each ER can really improve outcomes in our community hospitals in ways you just can't imagine. And we would celebrate these victories, and the hospitals would come back to us and say, "This is incredible. People are seeing rapid improvement," as we would go through our PDSA cycles. And then over the marathon of our first PRQC, we saw dramatic changes from beginning to end that were reflected in the readiness scores. Next slide, please. And that led us to say that this is both a marathon and a sprint. It is long-term goals, but you can make incredible short-term changes with QI projects. And that includes things like weighing children in kilograms, pediatric vital signs. We had the disaster preparedness and the transfer QI projects. We have a few different ones here, but you don't have to wait long times to see big changes in whatever it is you're trying to change. Next slide, please. In my role in leading the community hospital, I also learned that getting the community hospitals involved. I'm in charge at St. Joe's Hospital, Lake St. Louis, which is one of the spoke hospitals to Cardinal Glennon, and getting a huge team involved. People still talk about it to this day, the changes we were able to make over relatively short periods of time that have been sustained. And even though there's turnover in the hospital, people are still interested in what we did a few years ago and very excited that this is coming up again. Our administrators, next slide, please. were also, well, frankly, they were a little skeptical at first, but once we would report back to them and tell them the progress we were making and show them, that we were also making progress across the nation, that this was not just our hospital, that EMSC encompasses hospitals from coast to coast. They were excited that we were part of that organization and that effort. And the more you report back to your administrators about what's going on, not only locally, but nationally, the bigger buy-in you will get. And that's really important too. It also taught us, next slide, please, how important it is just to say thank you for everyone who participates. And, I learned that from Dr. Remick and her group in the first PRQC. We were lucky enough to have an incredible group teach us how to do QI projects. But each time that we, attained some goal, they were saying thank you, and they're very grateful, whereas I was very grateful to them. So it is an incredibly supportive group that provides resources that will last you throughout your career. And just remember to say thank you to the people who are participating with you. It's time really, really well spent. And that's all I have. So thank you for listening to my first PRQC, and I'm really looking forward to the second PRQC. So we'll turn this over to Christine next.
Hi, everyone. Thanks, Tim. My name is Christine Espiotis. I'm one of the third-year Pediatric Emergency Medicine Fellows at the Children's Hospital of Pittsburgh. And today I'd like to talk to you about the value of the PRQC in the hospital setting. Next slide. I'd like to begin by speaking about the importance of having a support system when embarking on improvement efforts. And I'm also hopeful that I'll help you see how these efforts can tangibly improve care. Next slide. In Pittsburgh, we've created over the last several years a regional support system that we've entitled the ED Outreach Program. With this program, we have sought to, as us at Children's being the content pediatric experts, to create a collaborative network of hospitals that we can help improve the pediatric emergency care of. We do this through a variety of modalities, one of which being through direct oversight and outreach efforts. We also support advocacy efforts at these hospitals. We share our academic resources that we have available at Children's, whether it be through protocols or pathways. And we also newly offer video consultations. So if there's a regional affiliate hospital that needs support for the caring of a child, we at Children's have the ability to kind of video in as the pediatric emergency medicine consultant, which has been fantastic in seeing improvement in care. Next slide. I think the why everyone is aware of, but I will reiterate for the sake of this presentation as well. We know that there's research that shows that the outcomes of children is directly correlated to how pediatric ready a facility is. And we are seeking to standardize that care no matter where a child presents for emergency treatment. We also know that these efforts align with best practice initiatives that are being supported by multiple national organizations. Next slide. I'd like to transition and hopefully provide you with some success stories that we have seen in our kind of brief program here at Pittsburgh with some of the improvement efforts that we have made. So first, I'd mentioned that we share a lot of our academic resources with our affiliates. And with that, we have sought to align further support within EMR systems. So utilizing algorithms as far as common pediatric chief complaints, what the steps we would take if that child were to present to us, sharing that with our network of hospitals, but also helping them to create power plans and order sets to further standardize as well as make that care a little bit easier for them on their end as well. In addition, one of the first steps we take when establishing this connection or partnership with a hospital is we actually have a site visit. And during these site visits, we see not only the environment that children are being cared for in, but also the equipment that every hospital has available to them. This varies widely, even within our hospital network itself. And as well, where things are stored also varies a lot. And so, through these visits, as well as through some of these, we like to call them pediatric champions, asking for our help. They have noticed, when a child presents, very ill, though maybe not frequent, it is a very high anxiety provoking, stress-inducing situation. And the pediatric crash cart specifically really needed kind of a revamping. And so that was one of our initiatives that we took. And we really asked them, like, what would be helpful? And they came back with, while there is a large variety of how pediatric crash carts were organized, there wasn't a large variation in adult crash carts. So based off of kind of that standardization, we mirrored the pediatric crash cart to the adult crash cart. So the muscle memory that the providers have when they are looking for, say, maybe airway equipment for an adult patient, they can easily translate that into the same drawer in the pediatric crash cart, for lack of better terms. In addition, because we know that weight-based is everything in pediatric care, we also created a color coding system for these pediatric crash carts based off of the Broslow color coding scheme. All right, next slide. In alignment with some of the initiatives with the PRQC, some of the improvement efforts that we have made has been obtaining weights in kilogram. I'll even be a little bit more rudimentary, sometimes even just obtaining a weight. We noticed that sometimes that was not a vital sign that was always being obtained. So that was some education and a lot of improvement that we saw based off of the importance of having a weight in a patient. It's just not always translated to the adult counterparts. So we saw improvements with that once, someone's aware of why it is important. In addition, the metric system is not something that we intuitively use in America, but it is in medicine. In a lot of scales actually have just something so easy as a lock button. So you don't have the ability to kind of toggle between the different systems. So you can't even use the pounds. So we've hit the lock button on a lot of scales of our affiliate hospitals. In addition, some of the scales have a toggle button, and we've put a little sticky note over that. So there's not even a toggle button available to them to switch between. With those simple efforts, we have noticed a significant improvement in weights being obtained in kilograms. And lastly, I think this might be my favorite improvement effort that has been taken on by one of our pediatric champions. She noticed as a lot of 48-hour bounce backs for fever or pain related complaints in children. And a lot of times the parents were saying they just didn't know kind of what they could do to help the child. And so she created these little pediatric packages. They have not only a dosing chart based off of the child's weight in kilograms during that last ED visit, but also a syringe to administer the medication in, and then just basic instructions and kind of tips and tricks on how to administer that medicine. And with this simple kind of pediatric package improvement effort, she saw a significant reduction in her 48-hour bounce backs at her hospital, which was just fantastic to see. All right, next slide. So in conclusion, I hope that this presentation allows you to see just the necessity of having a support system and a true affiliate network, not only for kind of context experts, expertise and guidance, but also for guidance amongst yourselves and support amongst yourselves. I think that this is just such a fantastic approach to seeking care and improving care for our children. Thank you so much.
All right. Hello, everyone. My name is Lisa Gray. I am a nurse with the Emergency Medical Services for Children Innovation and Improvement Center. Prior to joining the EIIC, I was a trauma program manager at a level 2 trauma center. So I am here today to talk a little bit about, very briefly, PRQC and trauma centers and why it's important if you work in a trauma center, to join and to recruit your friends to join who also work in trauma centers. So, as you likely know, the American College of Surgeons has adopted PEDS Ready language in the trauma standards. It is, I think, speaks volumes that the college has incorporated these standards, really placing a priority on caring for injured children, no matter where that child presents across the country. Our national system is very equipped to take care of adults, and now is the time to elevate the quality of care for children in our national trauma system as well. And by joining the PRQC, you can do that. Next slide, please. I'm going to talk a little bit about access, because what we know is that children likely present to an adult trauma center or a non-trauma center before they would present to a pediatric trauma center. So looking at your screen, while this data is a little older from 2017, the U.S. Government Accountability Office estimates that 57% of the almost 74 million children in the U.S. live within 30 miles of a pediatric trauma center that can treat injuries regardless of severity. The only geographic area with 100% coverage to a pediatric trauma center is in the northeast portion of the country, excuse me. In areas without pediatric trauma centers, injured children have to rely on adult trauma centers or non-trauma centers for their initial care. 88% of kids live within 30 miles of a level 1 through a level 3 trauma center, and there are only 37 states that have 100% coverage to those trauma centers as well. This tells us the critical importance of all adult trauma centers, no matter what your level, being ED, in your ED being pediatric ready. Next slide, please. And if we'll click through that, please. Thank you. Studies have shown that trauma centers are inconsistent in their level of readiness to care for children. Many lack important parameters and guidelines, many of that you've heard of today, such as recording pediatric weights in kilograms only in the presence of a quality improvement process that includes pediatric specific measures. By participating in the PRQC, your trauma center can work on these important processes. A recently published study by Dr. Craig Newgard and others looked at injured children brought to 832 emergency departments in the US. This research on trauma centers was the first to dig deeper and evaluate the association between pediatric readiness of emergency departments verified as trauma centers, in-hospital mortality, and in-hospital complications. In the study of over 372,000 injured children receiving initial care in an ED that had a pediatric readiness score within the highest quartile of readiness was associated with a 42% lower odds of death. The authors concluded that if all children included in the study had been treated in emergency departments in the highest quartile of readiness, meaning their pediatric readiness score was higher, an additional 126 lives might have been saved in each of the 6 years for which the data was collected. That is over 700 children's lives that might have been saved if trauma centers had invested all the time and resources required to better prepare for stabilizing pediatric emergency patients. Next slide, please. So a little bit more about the trauma standards. So as I mentioned, the American College of Surgeons has incorporated pediatric readiness standards into the grade book, stating that each hospital or each trauma center must evaluate their pediatric readiness score or their pediatric readiness, and then look at that gap and make an action to improve pediatric readiness. So what we also know is that across the country, there are only about 40 to 45% of emergency departments or hospitals that are trauma centers. So that leaves either non-trauma centers or state designated trauma centers. So one could say that a state designated trauma center could go ahead and elevate standard of care by including pediatric readiness language into their standards as well. States are starting to do that, and Texas is one of them. So starting sooner rather than later by joining the PRQC, you can really get started on those initiatives ahead of time. Next slide. And since this college has incorporated Peds Ready standards or Peds Ready language into standards, we really have started to talk about emergency departments really collaborating with the trauma service, working on a shared vision for children, all children in the emergency department who seek care there, utilizing the infrastructure of the trauma program and the expertise of the trauma program manager and others to include the PEC and pediatric readiness initiatives, really meshing those two departments together and really working on caring for injured children, and actually all children, medically and injured children. Without a doubt, if you have taken your assessment and you know that you have some gaps, the Pediatric Readiness Quality Collaborative is one way you can demonstrate to the college or your state designating body that you really are working on pediatric readiness initiatives. Next slide, and I will turn it back to Christina.
Thank you, Lisa. My name is Christina, and I am a project specialist for the EIIC Quality Improvement Collaboratives. Next slide, please. Registration for the collaborative is now open through June 6th. Once you register, you will get a confirmation email with next steps. The designated team leader should be the only person to register because we want only one registration per ED site on behalf of the team. We want the teams to be multidisciplinary, and it would be ideal to have 2 or more people on each team. Please scan the QR code or go to the link to register. Next slide, please. The collaborative will include opportunities for you to attend presentations by experts on various topics such as Intro to QI, pain management, weight in kilograms, assessment and reassessment, suicide, data sampling, and data literacy. Next slide, please. As you can see, this calendar illustrates the collaborative sessions which occur on the 2nd Tuesday of each month until August and on the 3rd Tuesday of each month starting in September. This calendar also shows when the fireside chats are scheduled and are on the process of being confirmed by the expert speakers. The additional webinars are in orange, and we're hoping that you all will be able to promote them to your colleagues. The orientation session to the collaborative is repeated, so participants can either attend on June 6th or June 20th, and those are highlighted in green. Next slide, please. These are some of the resources that support the collaborative, and you will be able to find them on the EIIC website. Next slide, please. The optional letter of commitment is attached to the registration. It is a mechanism to discuss participation in this important collaborative with your ED or hospital leadership. This letter opens the door to communicate the impact of this work on quality pediatric care, and in case of staff turnover, it can help to support replacement. Next slide, please. As you have heard from others, this QI collaborative is not only important, but there are many incentives to join and support your participation. Next slide, please. We will be offering CE credit for physicians, nurses, and social work professionals. The requirements are listed below. Next slide, please. There are 2 additional promotional webinars that are coming up. We would appreciate if you could promote to your colleagues. The first one is for facilities in rural areas, and the second one is hosted by the American College of Emergency Physicians. The QR code to register for the first webinar is listed or the link. For the ASAP webinar, the registration will be on our website as well. Next slide, please. I'd like to thank everyone who participated on the planning of this webinar, especially the speakers. I would also like to thank all of you for attending this webinar. If you have any questions, please email PRQC@emscimprovement.center